Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Thank you to our sponsors, Altum Dental Lab Group and RDT Dental Lab in Toronto. Hello, my friends. Welcome back to another special episode. This episode is with my friend, Dr. Karam Ashoo, who is an endodontist in Toronto, and he's going to tell us everything you want to know about cracked teeth. And by the end of this episode, you're going to learn about diagnosis, prognosis, and management of cracked teeth. So just to give everyone a little bit of an insider secret, this is actually our second time recording this episode because the first time the volume wasn't the greatest. So I told Karam, I said, we got to do an endo retreat. We got to do this a second time. So Karam has the privilege of being the first guest on the podcast to come back second time. But really, we didn't have a first time. So Karam, welcome.
Thank you. Thank you. I'm so happy to be here again.
So happy to have you. Tell us about yourself.
Oh, okay. I'm an endodontist. I work in Georgetown, Ontario, and in Toronto, Young and Davisville. I have two offices there, and I teach at the University of Toronto at the Graduate Clinic. And my office, we're a very modern office. We've got all the toys. We, do modern endodont engage in modern endodontics, if that's a thing. Um, but I'm lucky enough to have two wonderful associates with me as well, who used to be my residents, and we're all sort of the same culture where we enjoy teaching. They all give courses and they all give lectures. And so it's a part of what we do at the office. So yeah, so it's kind of a nice environment to be in.
Oh, that's great. It's great that you're mentoring us now. Just like you mentor your residents who are now your associates. So thank you.
It's not so long ago where I was on the other end. So for everyone
True.
who's looking for a mentor now, keep in mind you one day will be that mentor,
Yeah, that's
right?
true.
You're a mentor
And
in progress.
oh, I like that. And I hope you don't quiz me on what you talked about during the first recording of the episode. But it was fantastic. So let's start with the diagnosis of cracked teeth. What are the symptoms that the patient's going to come in with?
Well, they come in with saying a bunch of things, and a lot of times it's our job to sort of funnel them down into what actually the problem could be. So they'll come in saying, I've got pain. And a lot of things they'll say is, it hurts when I bite a certain way. Or it only started hurting after a post was put in my last visit. Or it doesn't hurt to bite, but it's only when I open up that it starts to bother. Some patients will come with more of a sophisticated knowledge like that. Someone might say, I accidentally bit down on a cherry pit and it's been hurting me ever since, or I have a filling that keeps falling out. And I've had a root canal or an apical performed in this tooth 5 times and it still hurts. So they'll come in and they'll say certain things. And, when you see this enough, you'll be able to say, or be able to see, certain patterns. And that can kind of direct you towards what's happening. But this is just, of course, the first thing. When we're working with a patient, we're trying to figure out all the pieces of the puzzle. And the first piece is their chief complaint. You've also got, to take their histories, their medical histories. Actually, that makes a huge difference as well. You need clinical testing, and then once you put all those pieces together, that's when you have a clear picture of what's happening. Imaging, of course, that's another one. So they're coming in and you need to formulate or put all the pieces in together, and that's when you can formulate a diagnosis.
Okay. I know diagnosis is very important to you, but what are the steps to diagnose? Like that tooth sleuth. How do you even use that?
I'm sorry?
The tooth sleuth.
Okay. All right. Okay. So the tooth sleuth, there's two types. There's the white one and the blue one. All right. The white one's just got a concave side. The blue one's got a concave and a pointy side. And so the concave side goes on the cusp tips, and the pointy side goes into your fossa and pits. And that can make a huge difference. So that's, of course, part of that's all part of your clinical testing. So once you get to that point, then you need to make sure that you've got certain instruments there. So in my console tray, I've got obviously a mirror, a perio probe. That's probably the most important thing there. The Bluetooth sleuth, and locking pliers. Those are the four most important things to have in there, because uh, you're testing the entire tooth. So you're just doing a regular endodontic assessment of the tooth.
Which vitality test do you do first?
So endo-ice is usually the one that has the highest success rate. So it's the most accurate. And so I would start with the endo-ice. Sometimes they'll tell you it only hurts with heat. So you can try heat. And sometimes they'll tell you cold actually makes it feel better. All of that is to figure out your full diagnosis. Now, what's your full diagnosis? You need to have a pulpal diagnosis, a periapical diagnosis, and then an etiology. If you don't have all those three, then you're missing information and you really shouldn't proceed. Right? And so depending on what you get, depending on your diagnoses and your etiologies, that's when you can decide what to do. And in deciding what to do, especially when you're dealing with something like a crack, communication is key. Right? So let's compare dealing with treatment planning a cracked tooth with treatment planning a regular endodontic issue. The regular endodontic issue, yep, you've got caries, it's extending into the pulp, you've now got necrotic pulp, perhaps an abscess. Your options are, if you do nothing, it's not going to be good. You're going to have continued symptoms, pain, and so on. If you can extract it, it's a very good option. It'll work almost 100% of the time. It'll get rid of that problem, but now you're creating another problem where you have a space. And you may replace this tooth with an implant, a bridge, a denture. Those would be your options. Or you can choose to keep it. You choose to keep it with root canal therapy, which can provide you with a very good success rate. About in our hands, it's about 90%, if not higher. And so when you present that to the patient, they're now able to see those three options and the allocated risks and the allocated advantages and the success rates. And when you have all of that information, then you can say, obviously I want to do this because I want to save the tooth, or I clearly want to pull it because I just don't want to have to deal with this anymore. It's a back tooth that doesn't bother me. So when you're dealing with cracks, the difference is, well, if you look at the cracks and you consider, all right, is it a bad crack? Meaning, is it a crack that extends all the way down the root? Is it perhaps a cuspal fracture that extends into the pulp that's causing this? And you'll have a similar success rate to no crack if it's just a cuspal fracture. Or is it the kind of crack that's somewhere in the middle? So a couple of things. Number one is, well, how do we know what kind of crack it is? Well, we won't until we're in there, right? And in order to understand and fully appreciate the extent and the type of crack it is, you need to be able to visualize it. And so having very good magnification helps. And it's actually necessary, because with magnification, you can actually see the extent, you can actually see whether it's stained. And so that's when you know for sure what kind of crack it is. And usually, we work with microscopes, so that's like 10, 15 times magnification. And I think anything less, you're missing information. So you're not able to provide an adequate prognosis for this, right? So you need to have that magnification. So then once you do, you also have to now consider, okay, well, is there probing depth around this tooth? And is the probing depth in the same area as the crack? So now you have to consider, what else is happening? How else is the crack manifesting? We know it's caused perhaps some necrosis. If it's also caused deep perio bone loss, then, what does that do to your prognosis? So all these things now have to play in to what you decide or how you decide to treatment plan this tooth. So what I tell patients is, well, if it's a really bad crack, I don't really give you an option to keep it because the success rate is next to zero. As if it's a crack that's very superficial, but somehow still it involves a pulp, I say, well, your success rate is quite good. I don't think we need to worry about any additional damage or any additional effects to the prognosis. But if it's somewhere in between, then you might be at 50%. And so this is where you have this very important discussion, ideally before there's a rubber dam on their tooth, because then they're going to ask you questions. And so the discussion starts with, well, if it's somewhere between a 50 to 90% chance of success, how would we decide? I would say to them, with 50%, it means that half the time when I do this, maybe 2 or 3 months down the line, you end up losing this tooth. So if you have the root canal done and you get a crown on there, you end up losing this tooth. If that's going to upset you, I don't suggest you do this. I don't suggest you try. But if you feel like you need to do this and then end up losing the tooth, you feel better because you did it and know that for sure the tooth had to be extracted, then that's the better candidate to do this procedure on. Because if you know that they're not going to be happy if this tooth has to come out, then I really don't suggest you try. But now they know it. They know all of this, right? They understand there is a chance that with what I'm about to do, they're going to potentially lose the tooth. And the whole reason is because of, with cracks, the prognosis becomes less predictable. So we say 50%. It's actually could be higher, but I'm not going to quote anything higher than that. And so because it's less predictable, that's why they need to have all this knowledge, all this information, so they can consent to this particular treatment.
Okay, so in some cases, it's very obvious that the tooth is cracked and has to be extracted, like it's split right in half. But I have difficulty with is, okay, it's sensitive to biting. I know there's a crack. Tooth pulp is still vital. So should we do the root canal? Should I drill away and chase the crack? Should I put a crown? Okay, what are the options?
Great question. If you've now determined that there's a crack in this tooth,
yeah,
you can say, your next thing is to consider what the pulpal status is. If the pulp is completely healthy, there's really no reason to involve any endo, right? If the pulp is now if the pulp is involved and you're having cold sensitivity, lingering, or maybe even heat sensitivity, spontaneous pain, that's not a good thing. And so now pulpally it is involved and you have to consider the endo. Of course, when you start to consider the endo, that's when you're like, okay, well, now we're going to do the endo, we're probably more able to visualize the crack and see the full extent. But let's say it's not involving the pulp. Let's say your pulpal responses are perfectly normal. Well, then what you can try to do is maybe either a resin or a crown cuspal coverage. So if you cover the cusp, theoretically you're engulfing the area that's involved, right? Or let's say the crack is in between two cusps, then you put a crown on and try to control it that way. Either way, you need to have cuspal coverage. The one thing, and you had asked me that in the last episode, is do we chase this crack?
yeah.
I don't think chasing the crack would help much, right? Because if you start chasing it, you may never get to the bottom of it, and in chasing it, you're compromising the tooth structure. So try more to keep things together, because it's not like you're chasing decay. That makes perfect sense. You need to get rid of all that. But with the crack, that's going to be much harder to do.
Okay, good. That's a pro tip, everyone. Do not chase cracks with your drill.
Not like you chase decay. No.
Okay, good. And then you mentioned how some patients have sensitivity when they bite, and some patients have sensitivity when they release.
Right.
Does that make any difference what type of crack they have?
Well, yeah, I mean, typically, I guess yes and no is the answer.
Okay.
So it can because that's what's used to be considered cracked tooth syndrome. But really, it amounts to typically just a coronal fracture. And so if it's this cracked tooth syndrome, it typically doesn't involve the pulp. And so a crown is what you need. So let's take a step back. You've got a tooth that has, symptoms upon chewing. It is, and it's not pulpily involved. When you put a crown on there, when you put a resin on there, you're not saying, okay, this is what the tooth needs so that we can alleviate your symptoms come back Tuesday, right? You are saying, this is a crack. The prognosis is less predictable. The success rate is less predictable than with anything else. So what we can first try to do is place some kind of cuspal coverage, be resin or a crown, and then we see what happens. If it resolves your symptoms, perfect. We don't need to do anything else. If it doesn't resolve your symptoms, well, this is what happens next. We can try root canal therapy. We can try, or we can go for an extraction. You need to lay that out. So once they see that path, and you're telling them that you're at this part of the path, just at the beginning, but you may end up heading that way, then they understand this is not necessarily going to resolve their issue. But that's the nature of cracks. You sometimes just can't resolve that issue. And
Yeah,
I've
it's
had
really
it
important to tell
where
the patients that
you have to,
it's
absolutely. I
like
mean,
we
they
can't predict what's going to happen. We're just trying things.
absolutely, yeah. And once the patient understands that, then they're like, when you message them or you follow up with them, they're not going to be upset. Oh, what did you do? This doesn't
Yeah.
work. I can't believe this. I paid all this money. No, they're going to say, yeah, we tried that first step. Clearly, it's not working. I think we need to move on to the next step. What do you think? Right? So,
Yeah, they're going to appreciate your insight instead of lack of oversight if you don't tell them, like, hey, this crack might end up extending far further than what I can see, and you might have to get your tooth extracted.
right.
Yeah,
And
so
so a follow-up is,
prepare them for that.
yeah,
Yeah.
yeah. And the follow-up is really important.
Okay.
So they'll
So it's,
understand. Sorry, they'll understand that, this is not over, right? You're
yeah, that's
following up with them,
true.
right? It's not
Yeah,
over. I'm just calling to see
this
how
is
it's doing,
serious.
right? Is it okay? Is it, is it getting worse? This is what we can do next. So
So is it fine for those, smaller cracks where the pulp is vital, the crack is probably just in the cusp, just in the coronal part, to put a temporary crown and then see if
sure.
the patient feels better? And then how long do you keep that temporary crown on for before you do a definitive
I mean, I'd usually say a month is adequate.
crown? Okay.
I'd say a month is adequate. Now, be ready for this scenario because I've seen it twice last week already. So a temporary crown is placed on a tooth. It feels
Yeah.
great, right?
Yeah.
No problems. Take the crown off, put the permanent, ouch.
Oh,
Something happens, the pain's now back, right? And I can't explain it.
yeah.
But now that the permanent crown is on and the occlusion is fine and there's no probing, unfortunately the symptoms are back. And so when the symptoms are back, that's when we have to start considering the other possibilities on that path that we discussed, right? And so make sure the patient understands, you've done this part, symptoms are gone. Hopefully they stay gone when we put the
Yeah.
permanent on there.
Wow. Yeah. So lots of communication, like you said, is so important.
Yeah.
Now, you said, whether the pulp is vital or not. So if the tooth is sensitive to biting and sensitive to percussion, but not sensitive to cold, so would that be a vital pulp?
Sensitive to biting, but not sensitive to cold?
Yes.
I mean, it's always possible because there are times that you have false negatives. And so you may not feel the cold, you may not feel the heat or
Yeah.
electric pulp test, but that doesn't mean that it's necrotic. It could just mean that it's super well insulated. It's, just very calcified chamber or calcified canal. So maybe there's a crown on there that makes it difficult. But I wouldn't jump to that conclusion necessarily. But if it's definitively I mean, if the pulp is huge and you have full access and you're still not getting a response, whereas let's say on the contralateral side you do get a
Yeah.
response, then yeah, you would consider that to be necrotic. And so if it hurts to bite and it is actually necrotic, then I would suspect that the crack goes deeply into the
Okay.
tooth, and so your prognosis is likely less favorable, right?
On the last recording, you went step by step into how you do your vitality testing and how you recreate the patient's symptoms. So can you
Yes.
share
Yeah.
that with us again?
Okay, absolutely. Um, so when somebody comes in with a symptom that you certainly can't produce or provide a diagnosis unless you've duplicated that symptom. And whether it's chewing sensitivity or vitality testing, there's a systematic way to reach it. The first thing I always do is start with the contralateral side. You're looking at a lower, maybe a 3-6, start testing on a 4-6, right? And try to get your baseline for what their response is to that test. So if we're talking about an endo ice test, put endo ice on the 4-6, they feel it, goes away, tell them, okay, so that's your normal. Now both you and the patient understand what their normal is. And you do the same test on that very tooth that you're suspicious of. And now you compare it. If it's the same, then chances, and they're both like high end or they're both subdued, then I wouldn't necessarily jump to a conclusion that there's a problem. But if it's contrasting, then I would certainly say there's potentially a problem there. So you start on the contralateral, go on the suspected tooth, and then test the adjacent ones after that. That way, there's no concern about overlapping sensations.
Wait a second. So if say the patient points to 3-6,
Mm-hmm.
says this tooth hurts. So you test the 4-6,
First,
and
yes.
then would you jump to the 3-6, or would you
Yes.
do, the 3-5 and 3-7 first?
I would do those
No?
after. I would
Oh,
go
so
4-6, 3-6,
and then
and
three
then
five
three
three
five
seven.
3-7 after things have
Okay.
calmed
Oh, okay. I
down.
also heard not to do the endo ice test right at the beginning because then the patient's really sensitive, might be really sensitive, and then you do the other test, and then you're not getting the most accurate
I
result.
agree with that. I
Okay.
leave
What
mine.
test do you do first?
I leave the endo ice to the very end.
Okay.
First thing I do is look. Checking extraorally, intraorally, see if there's anything that shouldn't be there. And then I start with palpating, gingiva, buccal lingual. And then rather than starting with percussion right away, you start with finger pressure. But you're not putting a lot of force on that finger pressure. You're very, very light because sometimes patients come in with an abscess, and if you touch it, they're going to jump, right? So you start with very, very light pressure on the tooth. If they don't feel it, you put a little bit more pressure and then a little bit more. The next thing I would do is tooth sleuth. The next thing I would do is percussion, probe, check mobility, and then finally the endo ice.
Okay. Can you go through all those steps again? So first you look.
First is extraoral, just
Okay.
looking, extraoral,
All right.
intraoral. Second is palpating the gingiva.
Okay.
Third, you're putting some finger pressure on the tooth, just very gentle finger pressure, and then eventually getting harder. And then that's followed by a tooth sleuth,
Okay.
percussion,
Yes.
probing,
Good.
and check mobility, and then endo ice.
Okay.
Endo ice is the eighth one.
Okay. Wow. We have to think of an acronym, all that to remember it. A mnemonic.
Yeah, no, it's in my chart. It's like the first letter of each of those tests is in there. So that's the
Okay.
yeah.
And then with the endo ice, If they just have a slight sensitivity to cold, is that okay?
I'm sorry?
With endo ice, if they just have a slight sensitivity to cold, is that
It's
okay?
it's all
So
about
when
it's all about
when
how it compares to the contralateral side, to a normal tooth,
okay, good.
right? So
Because
that's your
each person's
basis.
different. Yeah,
That's your
that's
everyone's
good.
different. So for some people, you put cold on the 4-6, they're jumping,
Yes.
right? You put on the 3-6, jump just as high. But that's their normal, right? They're just
Okay.
scared out of their minds when they're in the dental office. So they're going to overreact to everything.
Okay.
Yeah,
Okay. One of the things we talked about at the first episode was that you like to give prognosis to the patient. Like you actually give percentages.
absolutely. Absolutely. So that's one of the things we talked about
Mhm.
here as well, because,
Yeah.
they in a normal endodontic
Yeah.
treatment planning, you give them all of their options and what the success rate for each of the options. So doing nothing, this is what's going to happen. If you extract the tooth, that's practically 100% successful in alleviating the
Yeah.
problem with this tooth. Creates other
Okay.
problems. You can talk about those, right? And then root canal therapy, again, in my hands, the endo literature will show that it's upwards of 90% success. And so you present that all to them. And if there's any variation in that, like retreatment, for example, could have an 80% success rate, or just depending on the nuances there, it could range from 60 to 90 as well. Apicoectomies could be upwards of 90%. And even another modality, which is vital pulp therapy. We hit on that on the last
Yes.
episode.
Mhm.
Yeah, guys, you should check out the last episode. So yeah, with
That
vital
was
pulp.
never published.
No, it wasn't. It wasn't. So that's vital pulp therapy, where you're like removing a chunk of the pulp, and trying to maintain the permanent tooth, whether it's in a child or adult. Again, upwards of 90% success, right? So all of those options have to be explored, and the success rate or the prognosis has to be discussed. Because only then can you truly give your patient the information they need to make that call.
Sure. Do you have that written out in your informed consent?
So if you're a patient at my office, when you leave, you have a printout of your X-ray, and I've drawn on it, and
Yeah.
there's essentially a flow chart showing, first starts off with the pulp biology and pathosis, then it talks about reasons that this can happen, and then with each reason, with each etiology, you have certain treatments that are available to you. So those are all listed. And so there's success rates and sequelae as well. So they have that. And I tell them, go put it on your fridge, go talk to your friends about it, think about this, and then let me know what you'd like to do. Because, and if they ever come back to me and they say, well, we never really discussed this, I can say, well, actually, this is the diagram that I provided you. And look right there, this is what it shows. And because we scan it before we send it off. Right. But it's
That's
super important.
really
And we,
good.
we do get a lot of compliments for that. And patients are so appreciative that we discuss things at such a depth. And so they're able to make those really, those difficult decisions sometimes based on all that information.
I'm going to give you a compliment on that too, because I think that's great for patient education, for informed consent, because during the consultation, you're just speaking, but people learn in different ways.
Right.
And as soon as you say root canal, they might freak out and not understand anything else you're saying.
Mm-hmm.
So this way you're giving something to them in writing. You have diagrams for the people who are visual learners. You have
Yes.
a flow chart. They understand all the risks involved, all the different types of things that may happen, like
Right.
endo retreatment, apioectomy, extraction.
Mm-hmm.
So that way when they come in for the actual treatment, like they know what to expect. You're
Oh
going to
yeah.
get less complaints.
Yeah. And,
They're
and,
going to
and
be able
some,
to, yeah, they're going to be able to
sometimes.
handle any complication because they know what to expect.
Right, exactly. And but sometimes despite your best efforts, it doesn't hit home. Because a lot of times I'd like them to repeat it. So I was talking to a friend of mine who'd suggested, why don't you have them repeat what you said to you, so that you know that they've understood this. And I've actually found that very, very helpful. Um, and so I do that. But yesterday I finished a treatment. The patient was super nervous. She's leaving. And then she's like, So, as she and I could hear her at the desk, she said, "So, did we do the root canal?" And I was just like, I just honestly, I drew it out. I showed her the X-ray. I explained everything. But sometimes, they're really anxious coming in, and
Yeah,
it
it's
becomes
true.
much harder for them to process a lot of this, right? And so, repeating it, drawing it, all of this helps, right?
It's
And
true.
some people, if you're drawing and speaking to them, that's perhaps not enough. You do that and then you put it all aside and you like look at them straight in the face, eye contact, and say, okay, so I know this is a lot, um, but this is the issue. The summary is this is your problem. This is why it's happening. These are your options, right? And a lot of times they'll ask me, well, what would you do? I'm like, I'll do even better. I'm like, if you were my sister or if you were my brother, this is
Yeah.
what I would do. And because I treat everybody like I would
Mm,
treat them because I
yeah.
want them to have the best results possible.
I like that. I also like what you said about asking the patient to repeat back,
Yes.
because that's also important for us. Because when the patients come in and they say things like, "Hey, it hurts when I bite down. It gets worse when, I release. It's sensitive to cold." Like we should repeat those things back to the patient because then they realize that they're being understood.
Right. Right.
And also they might correct you and say, "No, no, no, I didn't say it was sensitive to cold," because we're so used to like every patient saying sensitive to cold,
Right.
we might just assume that.
Yeah. No, and I
So
spend a
we
lot of time in history. So with the history of the present issue, um, and I go through it. So someone will tell me, you know what, about 4 years ago, I had an incident where I had a
yeah,
filling done, and I'll just listen. I just wait and wait and wait, and so I go through it, and so all the pertinent information I go over again,
good,
and once they've agreed to that, they're starting to process it the same way I process it because I
good.
put it in chronological order with all the relevant points there, right? And so they're starting to see the picture I'm getting. So
Yeah,
that's helpful. The other thing I like to do is when my assistants bring a patient in, they interview them first. And so they'll ask them, so what brings you here? You're having any
yeah,
pain? And so they'll tell them. And then I go in and I'll ask them again. And a lot of times the version of the story changes. And so I could see my assistant's eyes rolling because that's not what he told me. And I know because sometimes I can hear it. But this has given the patient an opportunity to analyze what's happened and
yeah,
remember things. It jolts their memory. And so they start to
that's true.
remember things and provide you with a clearer picture of what's happened.
Yeah, that's good. And also, I'm going to give you another compliment on the handouts that you give your patients. I think that's so important because nowadays, with the internet and AI, our patients are looking things up online. Like we do it too. I don't
Hmm.
blame them. But then they might get false information because everything says, "Hey, you have cancer." So in this case, like, they're like, "No, this is customized to me. This is the
Right.
diagnosis and prognosis that my dentist has given me based on my symptoms and the
Hmm.
diagnostics that were done." So
Yeah.
it's very important that we give them that information.
Yes, I think it's helpful, and engineers love it.
Oh yeah.
Engineers are like, this is great. I wish everyone would do this. This is awesome.
And then they ask you about the materials and then the flex strength of the NiTi files and yeah.
They're too distracted by my flowchart to be like, what is going on? This is amazing. One thing we didn't hit on though is imaging and
Yeah.
how important is imaging in helping to diagnose any endo problem really, but specifically cracks. And so what we're used to using, conventionally are 2D images. And those are great. And a lot of times you're able to tell what to expect. Before I go into a tooth, about 80 to 90% of the time, I know if it's going to be cracked or not. And once or twice a year, I'd be surprised based on that. And so for that reason, I would go in and verify. But sometimes you need a 3D scan, so a CBCT. So, we can do that in our office and that's fine, but it's not always necessary and it's not always diagnostic for a crack, right? So if a crack has progressed a certain way, you're going to get that bone loss that's narrow that goes around the root. And that's usually a telltale sign. when you see it on a CBCT scan. But if a crack is new and the tooth is vital, it's unlikely, not impossible, but unlikely that you're going to see any signs of this on a CBCT. So for that reason, we don't ask for a CBCT for every case, just the cases where we know it's actually going to help us in the diagnoses. So, and there are cases where it does help, absolutely.
Okay. And how about those like transillumination? Like you can shine your curing light. Does that help to see cracks?
It'll help you see it, absolutely.
Okay.
Right. And sometimes it's just even the way you shine the light on the overhead on
Okay.
the tooth. Sometimes you can see that, but that won't tell you how far down it goes,
Okay.
right? So if it's because there's different stages or different grades of the crack. It could be just a superficial craze line, which is exclusively in the enamel. It could be a cuspal fracture. It could be a fracture that extends deeper into the pulp or deeper apically into the root. Or the last is a split root, right? So when you get to that stage, it's hopeless.
And Karam, you've been fantastic sharing all of your expertise, mentoring us on the crack teeth. Is there anything else you'd like to talk about?
Anything else I'd like to talk about? Oh my goodness.
About with crack teeth, not work-life balance.
No, no. I'm still trying to figure that one out. I've got two young kids and they keep me very, very busy. And so between the two kids, the two offices, and being at U of T, I still have to figure that one out. So if anyone has any pointers for me, I'm more than happy to take those. No, my associates, I like to toot their horn because they really are great people and great clinicians. And so, what I'd suggest is looking for their lectures. For example, Alice Lee gives a great full day hands-on lecture, and she talks about cracks and she talks about just basically all aspects of endodontics, start to finish. So that's a good one. She gives that every year. Mike Tiedemann gives a great lecture on vital pulp therapy. I think if we're trying to get him on
Yes.
to do a
We'll get
segment,
Alice on too.
yeah, to do a segment on that. So anytime you're starting off, this is the new dentist study club. You're
Mhm.
starting off, and I'm part of a spear group where we have new dentists coming in as well. And the one thing I tell them is, you're as a general dentist, it's very isolating working by yourself, right? And trying to figure everything else on your own is really difficult. I practiced as a general dentist for a while before going into endo, and so I'm sort of familiar with that. But what you have to understand is, living in a city like Toronto or any other kind of metropolitan area where you have the specialists available to you, these specialists are very appreciative of your sort of referrals, very appreciative of you working with them. And so they should be, and probably will be very happy to talk with you about certain cases, helping you diagnose certain things. And they're a resource that you really should use and they're part of your community, right? These are your people. So with our referrers, they text us or message us every once in a while during a study group. They'll come in and they'll have cases to show, and we're so happy to discuss it. We're really into this, and being educators and sort of specialists in our field, we love to help with that sort of thing. So reach out to your people, reach out to your specialists, and realize that you are a part of that community, and it's really going to help you in the long run, I think, because I remember being mentored, I remember being helped, and it made a world of a difference for me, and I'm more than happy to do that for like the people I work with as well. So reach out to your people.
Thank you. Actually, that's the best tip you gave. Like all your information on crack teeth were great, but the fact that you said like, hey, contact your specialist
Yes.
for help
Yeah.
because you're in it's going to be the best for your patients and you're going to grow as well and you're going to have a better connection with the specialist that you referred to.
Absolutely. And the easiest way to meet them, I mean, you can just cold call them, but the
Yeah.
easiest way to meet them is at one of the study clubs.
Yeah.
Like
I
join one
thought
of
you
the
were going
study
to
clubs.
say take your endodontist out for dinner.
Yeah. Listen, if they that's the whole life balance thing again. I'm not very good at that. But find a study club where they're a part of, find a
Yes.
time where you can speak to them. Absolutely. I'm sure, it's a relationship where they're appreciative of your input into their practice, your referrals, and I'm sure you'd be very appreciative of them sort of reciprocating that appreciation, right? So take advantage of it.
We appreciate you, Karam. So you know, check out Karam Ashoo, check out Mike Tiedemann, Alice Lee for any upcoming courses that they have. Karam, how can the audience contact you?
You're more than welcome to email me, karam@davisvilleendo.com. If you can provide them with that link,
Yeah,
Sanjay,
I will.
that'd be great. But yeah, I mean, anytime, like if you're in the area, you want to reach out, then by all means, if you're looking for an endodontist in your area to sort of be with, I know some, I don't know all, but yeah, I think it's a fun profession to be in. And it's even more fun when you do it as a group.
Oh, thank you, Karam. So email Karam, invite him out to dinner, learn even more from him. Thank you, Karam,
I
for
think
the part.
I'll have plenty more time in about 10 years.
That's true.
Plenty more
When
time
your kids are older.
when my kids don't want to see me anymore. Absolutely.
So thanks for part two of what was only a part one. We appreciate that, Karam.
Anytime. It's my pleasure.
and
Thanks for
and
having
thanks to
me.
the audience for listening in. Stay tuned for the next episode. Bye, Karam. It was fun.
Bye. All right. Take care.
This podcast is sponsored by RDT Dental Laboratory, your full-service dental lab in Toronto. RDT Dental Lab will help you grow your practice through education, predictable restorations, and high attention to your clinical needs and patient experience. Check them out at rdtdentallab.com. Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.